Good afternoon. I see a lot of folks starting to join us. I'm going to give it about 30 to 40 more seconds and we will get started. All right, we are going to go ahead and get started. Good afternoon. Welcome to the HFMA Colorado chapter webinar series. Make sure that you follow us on our social media pages for information about upcoming events and webinars. We do want to take a moment to recognize our annual business partners. Their support allows us to operate our chapter and bring our members quality education and resources. We hope you'll take a look at them first when your organization needs services or support. A reminder, certification is included now in your membership. Study materials are available online and all modules can be completed on demand at a time that is convenient to you. It's never been easier to get certified. If you're interested and want more information, please contact the chapter for more details. Today's webinar is a case for VBC readiness assessment. Please, during the webinar, use the chat box if you have any questions. And with that, it is my absolute pleasure to introduce our speakers. Cal has a decade of experience in VBC implementation. Prior to Nordic, he leveraged VBCs to help Aetna expand its Medicare Advantage offerings in new markets. He also helped build the engagement and analytics model to manage VBC performance for a regional Blue Cross Blue Shield plan. Cal is now focused on Nordic's expansion of services to health systems and payers to foster payer-provider collaboration and to achieve success as they transition to the value-based paradigm. Cal also has a deep understanding of delivery systems, having served in various leadership roles at Kaiser Permanente Northwest for over 6 years. We also welcome Jake Alexson, who is a director in Nordic's performance improvement team. He leads Nordic's wellness and population health team, which includes operational and technology integration to serve healthcare systems in their value-based care journeys. Jake has more than 15 years of healthcare experience with a background in Epic EHR optimization, certified in Healthy Planet, ambulatory reporting, and inpatient applications. With the evolving healthcare landscape, Jake is advising multiple organizations on solidifying value-based care goal strategy. Welcome, Jake and Cal.
Thank you for having us, Jessica. We wanted to thank the HFMA and also for folks for joining the call today. We look forward to sharing with you our experience on how health systems are tackling value-based care readiness. Just a quick overview of who Nordic is in case folks have not worked with us. We are a global consulting firm connecting health systems, people, process, technology to create a healthier world. We are an award-winning firm, receiving best in class for numerous areas in 2022, one of which was rev cycle optimization. Some of you may know our teammate Eric Wilberg, who lives in Denver and is currently the secretary of the Colorado chapter. And this discussion is a follow-up from our HFMA National Leadership Retreat, where one of the areas focused on aligning payment systems. So again, we look forward to sharing with you what we're hearing from organizations in regards to value-based care readiness and alignment across their organization. With that, I'm going to kick it over to Cal to dive in.
Thank you, Jake. Thank you, everyone, for the opportunity to come in front of you. This is our third HFMA conversation, starting at the national level, then at a regional level, and now we're at the chapter level. So we appreciate the opportunity to have this discussion with you. This being a smaller group, we welcome and we want to make this a little bit more interactive. So Jake and I are going to kind of go through the slides together and interject as appropriate to add color commentary to the slides. And he's also going to help us monitor the chat. So please do ask questions. We don't want to be talking for the whole time. We want to make this a valuable dialogue and really just enjoy the benefits of having a smaller group and having this conversation with you. So during this conversation, we're going to start at high level, looking at some of the trends where things are going. Then we're going to talk about what we think or what a VBC assessment looks like. I will use some examples of our current work with our clients to get into a little bit more detail to give you some perspective of what we're talking about. During the course of that, we will include a couple of survey questions to kind of get a better understanding of where you all are at. So we're looking forward to that. So why don't we go ahead and get started? All right. So first of all, let's look at kind of where the trends are leading when it comes to alternative payment models. I'm using APMs and VBC a little bit interchangeably. CMS uses APMs, but and they have different models, and then most payers will use VBC. So I'm kind of using both, but it's interchangeable. So here I'm kind of presenting some information around that we got from the Healthcare Payment Learning and Action Network. So this is the latest report that was available from them, and it shows you the trends of where VBC is going. So on the left-hand side, what you see is just the overall spend going through VBC programs, right? So, and it's by line of business, but overall they tracked it all the way to 2015, but the breakdown by line of business came in a little bit later. But as you can see, Medicare Advantage or Medicare Advantage is leading the way, and then Medicare Fee-for-Service is the next one, where they have the most dollars going through VBCs, and they're trending, higher when it comes to that spend. The graph on the right, on the other hand, is really looking at risk agreements. So this could be the fee-for-service based upside downside agreements where there's some downside, but it's also population-based payments that are kind of being instituted that are more akin to taking full risk for those populations, or at least for certain services to be rendered to those populations. So the takeaway here is that the trends are showing that at least for government lines of business, the move towards downside risk is here. And then, yes, most likely the pandemic probably slowed it a little bit in some ways, but in other ways it probably accelerated it. So I think the trend is going to be continuing here to stay. So we wanted to kind of highlight that with you at a high level. Jake, any comments?
No, I think we want to jump into our first poll here to get a sense from folks as far as where their organization is at. So I think Jessica's going to launch the poll. What type of value-based care arrangements has your organization implemented thus far? Is it more on the upside only, downside? Are there folks that are not sure what type of value-based care arrangements we have? So I see some results coming in. We'll give folks a second here. About half of the folks that voted. Cal, are you able to see the results thus far?
Yeah, I'm seeing the results, and I think it's kind of, what I was expecting. So we'll wait for Jessica to give enough opportunity. I think that she's paused the results for the polling. So, all right, well, upside only. So that's great. I think later we're going to ask a question about what lines of business you guys are doing that in. So I'm really curious and kind of understanding what people's downside agreements are, what lines of business they're in. But what I'm seeing here, and Jake joined in because this is what you and I wanted to kind of know a little bit more, that is mostly upside with limited downside, probably in some agreements with some payers, or perhaps it's Medicare MSSP track that you're referring to, and maybe some folks are taking some downside risk in that. But yeah, so I think this is a good mix, and it's representative of kind of what we're seeing. I think what's a little surprising is that there are folks who may not be sure what kind of arrangements you have. And so I think that's interesting to figure out why that may be, and really understand, how we can, get more engaged around that. So
yeah, Cal, I think it's an opportunity for folks to engage the right stakeholders of their organization to really start asking some of those questions as far as where the strategy is, where the organization is headed.
And you and I have seen a lot of that, where certain stakeholders you would think are going to be in the know on where your VBC strategy is and where you're headed, and they're not. And then so part of what we're going to be talking about in the assessment is bringing all those stakeholders together and really creating that alignment. So all of you that are in various roles, whether it's finance, IT, or clinical operations, have a good sense for where you're headed on your VBC. Great. Let me just close this out. Okay, so we kind of started this conversation already, but I wanted to spend a little bit more time just because I've been in this field for a little bit. There used to be a time when value in value-based agreements was defined a little bit differently. It was a lot more lenient, engaging a provider group to help to have them close care gaps was considered a value. Now, like that's okay, well, you should be doing that. And, it's not considered as much of a value when it comes to value-based agreements. The movement really is, how much downside risk are you going to be willing to take, what percentage, and whether it's going to be full risk. So the definition of value is evolving a little bit. And we wanted to kind of touch on that because that kind of goes towards where the trend is headed as well. So the places where you really kind of probably sense that is your contracting teams are getting pressures from the various payers, be it government payers or commercial payers that, hey, we've been talking about VBC for a long time. It's probably time where we kind of start thinking about when you would be willing to kind of consider some partial downside risk down the road. So that's kind of one area where you're going to be sensing a lot of pressure, and I'm sure your teams already have. But the other area where this is kind of coming from, in our experience, is that there's been a shift of cost to consumers from employers and payers and a lot of payers. And so I think that's been tapped out because most of us are in high deductible plans where at times they almost look like just catastrophic insurance because you got to cover the first 10,000 of your care. So it's very, very difficult to compare that to the times where we used to pay $1 for your prescription. And I remember those days. So the next frontier of cost shifting really is moving risk to the delivery systems, and payers are talking about this as a strategic imperative to shift some of that risk to payers. So that's the reason it's coming this way. Another topic that is really in discussion right now, and many of us are delighted that it is social determinants of health and addressing those determinants and the role that they play in members' and patients' health. So the organizations that are able to kind of address social determinants are going to be more successful even in their upside-only agreements, because if you're not addressing those things in somebody else's, you're incurring the impact of that in your upside-only agreements. And to me, that's effectively cutting your slice, and it's really akin to like downside risk. So I think that's a reason, value needs to be thought of a little bit differently. So the last thing I want to talk about is that many health systems have their own self-insured plans. And so in a way, many health systems have already been taking underwriting risk on their own populations. And we've seen a mix of how well those populations are being managed and how well that risk is being managed. Some organizations do a far better job than others. But in a way, my point here was you're all already taking downside risks. So it's important to understand, to learn how to manage that risk from an underwriting risk perspective. So any comments, Jake?
No, let's jump into the why. Why now?
Yeah. Yep. So this is a theme or a question that comes up often when we talk to people about being ready for VBC transformation, being ready for downside risk. It's coming. They want to know why now, because I'm dealing with staffing issues. We have inflation. I'm concerned about the economy. Is this really the right time for me to be focusing and investing in a VBC readiness assessment, where some of those downside risk agreements may not come for years? And I think this is exactly the time where you want to kind of set the foundation for when those times do come, because it's during this change, the time of economic hard times and distress, that you really can, implement transformational change. So, and why is that important? And what are the kind of factors that this is going to affect and we should talk about? And so, first and foremost, to me, as you know, a lot of Medicare plans and CMS is going in this direction, but so are commercial plans and employer groups. It's to improve the patient experience. Moving into VBCs faster allows you to get reimbursed for traditionally non-reimbursable services and in services that you can use to address social determinants. So in a way, being engaged in VBCs being maybe ahead of the curve allows you to have an improved patient experience. I think that's very, very important. The other reason that may be more a financial reason is that many of you have been reading about it or already experiencing it. There are well-funded primary care groups that are coming into markets. They're taking full risk with payers, and they're specializing in certain populations, usually Medicare and Medicare Advantage. And they have a lot of wraparound services, and their goal is to keep people out of hospital and high-cost acute care facilities, deliver as much care at home, and then reap the rewards of all that work and the value that they generate. And so this is definitely going to have an impact on brick and mortar hospitals and health systems that have really not had to deal with this before because they had their own providers that in referral sources that were kind of pretty well implemented in their local markets. So this is definitely a concern. The other thing I want to talk a little bit about is what we probably just still coming out of it is the pandemic, right? So you want to have some financial insulation. So those organizations, and this has been observed through data, that were very reliant on fee-for-service revenues, obviously, and maybe some of you were those organizations, really suffered when that demand for services froze practically overnight. And so, having value-based agreements and some population-based payments can allow you to kind of insulate yourself from those ebbs and flows of the demand that can happen, with catastrophic situations. And hopefully we don't see one for many, many years. It's also important to talk about, since we're talking about staffing issues, about the importance of being ahead on the value-based spectrum is the recruitment and retention of clinicians. I think, and I know some of you may agree, there was an old guard of clinician, or there is an old guard of clinician where population health really was not something they learned in medical school. It's not something they probably even valued because they were really based, their practices were based on the encounter system and face-to-face appointments. But newer clinicians that we talk to, they're looking for organizations that have population health infrastructure, that have quality incentives, that are part of value-based agreements, because these folks want to manage their panels and get rewarded for that hard work of keeping people healthy. So it's really important to make sure that you are part of the VBC community. So, Jake, any comments, thoughts?
Just that energizing key providers, stakeholders. First step is education. We're gonna touch on that here in a moment as far as the importance of educating and informing key folks.
Cool. Yep, absolutely. We will. I think engagement comes from education and understanding why you're doing what you're supposed to be doing. And I think that's a key. We've kind of learned that, you and I have, and we all have over time. But to continue a little bit more on this theme of this is not going away and why we should work on it, is that same organization, HCP Land, conducted a survey of 73 plans and five Medicare, 5 state plans and a few Medicare plans as well. And the respondents, and this is amazing, so 9 out of 10 said the VBC activity, the alternative payment model activity, is bound to go up. So that in itself is amazing. But what's amazing to me is that 0 of them said it's going to go down. So that's here to stay. The payers are building infrastructure and foundation to continue to engage their providers in different models. And so the models for your big health systems, for smaller practices, and all those ACO aggregators that are coming in, or ACO enablers, payers want to work with them to bring in the smaller practices into the VBC realm. So it's here to stay. It's not going away. So when you ask the same respondents, what do you think the top 3 barriers for adoption are? It's provider willingness, provider ability, and provider readiness. So I think that's important because I think I can lump all of those into what we would go. Let's go to the next slide to find out why. Why is there that much hesitation? And I think the conclusion that we've drawn is that really it's a fear of the unknown. It's organizations are not sure if all the stakeholders that you need for implementing VBC can align behind each other, come and collaborate together, and generate value for the patients and for payers, and really provide cost-effective, high-quality, patient-centered care. If you don't know that, I mean, it's hard to be gung-ho and move towards risk or move into VBC or more advanced VBC plans. So how do you overcome those fears? You know, I feel like getting informed is the first great step, which is why we're going to be talking in a little bit more detail to you about what the VBC readiness assessment is, what it can do for you, and how you can generate some value out of it for your organization as you look at the next 3 to 5 years of your VBC journey. So a VBC readiness assessment, we'll talk a little bit more detail what the goals of that is, but Jake, do you want to talk a little bit about your experience with silos in this space? I think that was good examples you had.
Yeah, I mean, I think that's one of the most challenging things that we've seen and heard from organizations is that value-based care touches so many different areas of the organization, so many key stakeholders, physician leadership, rev cycle, managed care. The key is really breaking down those silos, identifying shared goals across those areas, and putting together that governance. And I think, you know, Cal, that probably segues into the kind of goals around an assessment.
Thank you. No, I mean, I think that's a great point, and thank you for mentioning all the different stakeholders we were just referring to. So when you look at the goals of a VBC readiness assessment and why you'd want to make this investment, I think first and foremost, a VBC assessment will give you a clear picture of your current state in all of those respective areas that we just alluded to. So different operational areas, lines of business, service lines. You'll understand where you are from a technology perspective, from a people perspective, and from a process perspective. And you're going to hear Jake and I talk about that a lot, because we don't view a process as just a process piece because it involves people and technology, and we don't look at technology just as a technology piece because of the other two. So we always mention those three together. So you'll get a good sense for kind of where you are. And as a result of that work, it'll allow you to build an implementation roadmap. So whether it's for foundational capabilities that you may not even have yet as you go through this assessment and you find out, or for more advanced capabilities that you envision that you need to be able to go to downside risk and manage underwriting risk for a large population of patients. So that's important. The other piece that this really becomes important, having an assessment done, is to understand your clinician and staff engagement, because none of these tools and technologies you put in place without their engagement is going to yield the kind of results that you are seeking for successful VBC implementation. So many of us have seen this time and again. VBC contracts get signed, it's implemented kind of in a half-hearted way. Some service lines are accountable for some of the metrics, others don't even know what the metrics are. And it can be really demoralizing when people in the organization don't even know what metrics they have in their VBCs and whether their department is even accountable for those metrics. And so you want to avoid that, and you want to learn to make sure, if that's where you are, you want to create a plan to get out of that area. But more importantly, in a positive sense, going through that process and engaging your stakeholders in understanding where they are can also in itself improve the morale and create transparency and trust and more engagement. So I think that's a really great way to think about that. Another piece that becomes important, and we've seen this time and again, health systems may focus too much internally and not look at clinical integration and collaboration strategies. And sometimes maybe they're not even doing that internally between primary care and specialty care, but you want to create a strategy and a plan for a deep understanding of where you are based on kind of how you're working well with your local healthcare ecosystem. If you're part of an ACO or a CIN, what's your role in there? What are the results you're getting out of that? So really understanding kind of what those clinical integration opportunities are. So that's important. Last but not least, you want to have a cohesive payer engagement strategy. You don't want to be in every payer's network necessarily. For some organizations, that's harder to do if they're academic centers, for example. But you want to make sure you're thoughtful about who you partner with, who you go deep with, and what those relationships look like and what you want to gain out of that. So Jake, any thoughts on the goals?
Yeah, just one thing to add is that it's very common for us to find one or two key stakeholders in an organization that sees this as a priority And one of the things that this can arm them with is understanding a clear picture, having that roadmap, that initial roadmap is going to help communicate to the rest of the organization that this needs to be a priority, based off of some of the things that Cal, you hit on earlier. So just wanted to kind of call that out, that it's not uncommon for there not to be alignment across the organization. And sometimes it takes one or two key stakeholders to really identify, get some of this in place to make some traction.
Yeah, no, and I think, Jake, that's a really great point, because sometimes when you start having conversation with that one person that reaches out to you thinking that this is something they may need, it's not even easy to find stakeholders or other folks that they need to be engaging within the organization, and what that governance looks like and what the transparency around the process looks like. So, I mean, I think that's a great point, that finding who the stakeholders are and how they can work together, and giving them a roadmap and a tool to communicate, or a process to figure out how to communicate better on what the impact they have on the VBC success is very, very important. So great. Well, let's go to the next poll question. So this is really about readiness and how ready you think your organization is for moving to risk. So I'm just very curious where folks land on this one. Awesome. Okay, so again, not surprising. So I mean, this is very informative, and it's very telling. So you are good and ready in some areas, probably ones that have been engaged for a long time around care gap closure. Maybe some of the primary care providers and teams have been doing that for years, but you don't have an overall aligned approach to it. So that's kind of the majority response. And so none of what we talk about in no organization is completely on one end or completely on the other end. So for the most part, this is really reflected here. You may not have an aligned approach, and some of your areas may be more advanced in VBC implementation than other areas, or more engaged. And so when we do an assessment, or when you consider doing an assessment, you want to look at your capabilities and readiness. It's not assumed or implied that one area is going to know exactly or how far advanced they are than another. So it's really understanding where each area or operational unit or business unit is, and then really understanding how that fits into the overall. So that's interesting. Cool. Any thoughts on that, Paul? Any surprises, Jake?
Yeah, I mean, just if you don't know and don't necessarily know how to find out, I think start asking some of your organizational leaders in managed care, the folks that manage your contracts, and start asking the question as far as where the strategy is that the organization is looking to go.
Yeah, and I'm impressed by that one group that's very ready. So that's awesome. Great. All right. Well, let me close my slide. So now we're going to go into a little bit more detail, and let's talk about what a scoping exercise would look like when you want to understand what areas you want to look into. So this is not intended to be an eye chart, and I don't intend you to read any of these things on the column on the right hand side, but the categories are important to understand. So based on our experience without working with our clients and our past experience, these are kind of the larger areas categories where we think you have to have something happening at a high level in high capability to be successful in VBC implementation, and these areas need to coordinate with each other. So on the right-hand side, we have specific functionalities and questions that we kind of, when we're looking at understanding where a client is about with vision and strategy, for example, you start asking those questions, and that's part of the assessment, is to understand and unpack where you are on those different functionalities. And if you have something that's up and running, for example, like care gap management or roster management, that's awesome. All your roster information is at the point of care. Every provider knows what patient is in what contracts and what VBC deal. That's great. But if you don't have it, we include that in the assessment. So what we do is what we recommend you do on your own or with your partners, business partners, or a firm, if you're choosing, is to go through this exercise and really understand for these different areas, what are the functionalities you need to include in your assessment. And then we'll give you an example of what this exercise, going through this exercise, looks like for a client situation scenario where we went through this part and really came up with some work streams to then go deeper in. And then those deeper assessments could be specific to your organization or specific to your geography and your pair mix and all that kind of stuff. So you can customize it, but these are just thoughts and ideas about these functions that you should consider in asking yourself where you are on that. So any comments on this, Jake?
No, I mean, I think this next slide is really gets into some of the overall focus of where we've seen, or essentially how to take that detailed list that you just had, Cal, up on the screen and put it into more of an action plan or different focus areas for the assessment.
Yep. So in a typical scenario, after we go through the scoping exercise, these are the kind of work streams for this example that we're sharing that were selected in this case. And I think of each one as kind of a mini assessment for that respective area, because you got to look at different pieces of data, different pieces of information, perhaps interviewing different folks and looking at identifying different stakeholders. And in each area, then you want to create a kind of a game plan, governance structure. And then at the end, as you think about bringing it all together, creating that final plan around how all these pieces are going to come together and how we're going to align our investments and our energies and time, and which ones are we going to work on first, to get us ready to that advanced state of value-based care readiness. And so the two in the yellow, Medicare strategy, risk adjustment, we're going to give you a little bit more detail on it. So I won't go through that, but in this case, the client really wanted to focus on CIN and provider engagement. So this is where you would look at kind of what data you're sharing, what kind of education you're providing those providers. Is there an incentive sharing program? What kind of clinical care management support they're getting to even be engaged around this work? What's their visibility into the VBCs? Roster management, I already alluded to. It's critical, and it's surprising sometimes to know how many organizations don't have a good mechanism for disseminating their pair rosters for different VBCs and programs they're in to the point of care where it's most important, or to the back office nowadays, where some of those things the patient needs to know, and they may have an impact on their cost sharing, et cetera. So that's important to know what the patients and which agreements they're in. Care gap is a great example, and Jake has a lot more experience in the space. How well optimized is your EHR? What kind of quality culture do you have? What kind of visibility do you have? Do you have dashboards that create visibility, and who's looking at that? Those dashboards, who's talking about the culture of quality and gap closure, and what kind of oversight you have for that? It's very, very important. And then if you're going to be managing total cost of care, or even if you're an upside only agreement and you want to maximize your total cost of care savings, it's hard not to look at practice variation in looking at your total cost of care from a big picture perspective, not just utilization metrics like inpatient admissions or readmissions, things like that, but just looking at how the clinicians are practicing, what's happening to the dollars coming in, at a PMPM level. So what's your approach to gathering that data to understand that? What kind of benchmarks can you bring in or have you brought in, and really understanding that? How do you manage those conversations when you do identify that there's a practice variation that's perhaps unwarranted clinically, and the leader has to get involved with those clinicians? But things like network leakage is also an important part of this consideration. Like, for the patients that you're supposed to be managing the risk, where is the care being provided, and how do you internalize that to say if your cost position is better than where they're already getting it? You may not want to bring cost patients that are getting it cheaper somewhere else, but there's clinical implications for that too. So it's not just the cost consideration of internalizing care. You may want to look at bundle payments as a strategy, for example, and you think you're confident that you could achieve some good results in that. So looking at that is very important. The last piece I want to talk about before we move to the details is proactive care management. Some of you may be wondering, well, what is proactive care management? What happened to care management? So I think care management to date has been very reactive, whether it's at the payer level or the provider level. They wait for a catastrophe to happen, or some patient, getting into a situation where they've incurred a lot of cost, or some adverse outcome has already happened. And then they're reacting to that because that showed up on their roster, and now they got to figure out how to mitigate those costs. Fine, it's very valuable work. You should be doing that. But if you're really going to manage underwriting risk, you got to be proactive about identifying rising risk and managing those patients that have not yet incurred high cost services, but they will if you don't do anything. And I think that's that shift that I'm hoping organizations, and we're hoping organizations will get through working on improving how they do care management, population identification. So,
Cal, three quick points here. You hit home on each of them, but the three in the middle, as far as roster management, that's population health 101, as far as identifying your patients and having those payer rosters and getting those patients flagged is a key first step. From a care gap closure standpoint, partnering with your payer and making sure that you have that super set of accurate data in your EHR at the point of care for your providers to ultimately close gaps. The third, around cost, a lot of organizations we work with have that cost data. It's the challenging part, or the next step is around what do you do with that data? How do you enable clinical change and transformation around costs and utilization data? Is where we're finding organizations starting to shift to. So, yeah. I was just going to say, again, these are 7 work streams. Some of the organizations maybe can prioritize these and determine where do you start. But this is really what we've put together as far as an all-encompassing value-based care readiness assessment.
I think you made such a great point, and I maybe I didn't state it or I missed it, and I really want to reiterate it. So each one of these areas of work are not just you doing your part. Each one of this has an opportunity and a piece that where the pair collaboration is critical. So not only do you just want to have your care gaps be most accurate in front of your provider when they're addressing them, you want to make sure you have a way to get that back to the payer, because that's how they're basing the payment on, right? So each one of these total cost of care is the same thing. Perhaps your payers can give you better benchmarks for your utilization or expenditures in certain lines of business or certain specialties. Proactive care management, there are ways to collaborate with your payers from a clinical perspective. Build care plans where you both have a role in play, whether you're a provider or a payer. So when we think of, and when you think of this, don't think of these as things that you got to implement on your own with your own folks. Each one has a feeder or a piece or a feeder back to the payer. That's a big part of the success, and you'll see that a risk adjustment, that's very, very important. Care gaps is very important, and care management, it can be very important, and it should be. So great point, Jake.
Yeah,
thank you.
You bet.
All
so
right.
I can take the slide, Cal, as far as diving into a little bit more of the details of the assessment. And again, I think organizations have this expertise in-house. This is an exercise that organizations can do, is internally put together, do these activities. First, analyze those contracts, make sure that each stakeholder that needs to be involved understands these contracts. What incentives does the organization have? So really identify that current state and start to put together that strategy. And how you can do that is by interviewing the key stakeholders across the organization. You're going to learn a lot as far as being able to educate, be able to increase awareness, data sharing. We've got a number of other areas here, but ultimately, if you look on the right, this can take some time of process for an organization, 12 to 16 weeks to put a full encompassing assessment together. But ultimately, what you want to have out of that is those things on the right, as far as being able to have that summary of current state, be able to have a presentation, to be able to take to leadership, to be able to show this is why the organization needs to move in this strategy. Another piece is having detailed recommendations or optimization opportunities across the way. So from a physician engagement standpoint, what type of campaign do you need to put together to be able to educate and roll this out? And then those last two are around technology, as far as the analytics and the reporting needs around this, and then the technology tools and the staffing. So people, process, technology, you see in the middle of the slide, that's really the lens that you need to have, is first the people, then the process, and then the technology to enable this. So some good details for folks, hopefully, as far as focus areas, as far as how you go about tackling this.
Yeah, Jake, I think let's continue and spend a little bit more time on this slide, because it's very important. One of the things that I really want to stress is that Jake, you and I have noticed this in our team. When we work with a client, even if somebody that we're working with is very highly engaged, you might need some additional champions within the organization to engage the rest of the organization and the additional stakeholders that need to be part of this. And so it's a huge undertaking, and identifying, physician executives and other executives to be interviewed for this kind of work, you really need to make a case, internally, and you need to have a champion that's willing to drive that and to drive that engagement. Because when your consultant or your own project management team or your an internal consultants you may have, when they reach out to those stakeholders to ask for results and ask for past information, a lot of that is a lot of work. And people, like you all know, people are super busy right now with the shortages of staffing and everything. People are wearing multiple hats, and so this can look like a big undertaking. And then keeping them engaged for 12 to 16 weeks sounds big, but I think what you get out of it at the end is very, very valuable. And the results you're going to gain in your VBC agreements are going to pay for this, and there's hopefully going to be great ROI for the different pieces we talked about. But just as a whole, going through this, it's a lot of work, and nobody's minimizing that. So you will have to champion this, and someone will have to champion this at a leadership level to say, hey, we ought to do this. This is where we're headed. And Jake, you can share as well, those organizations that have created a path for when they want to shift to downside risk and how much of their dollars are going to be shifted to downside risk based on their market realities, they tend to have an easier time, but relatively speaking, of engaging the teams and engaging everyone. But even then, when you have a clear path that in 5 years, we're going to be 60% of our revenues going to come from at-risk agreements, it's still very difficult to gain this kind of engagement for this, but it doesn't mean it's not worth the effort. So I wanted to share that. All right, we have our third poll question. We're just curious what line of business you most likely be taking downside risk. All right. Yeah.
Appreciate folks participating in the polls.
Okay.
All right, Cal, any thoughts?
Yeah, so I'm a little surprised on the commercial. Perhaps there's some large employer groups that are willing to work with their payers and have put agreements in place. But traditionally, that when we looked at that trend data, commercial lines of business is very difficult for downside risk, because it's really hard to allocate the risk back to the purchaser of the services. But if you have a large employer groups or retirees, I mean, I think that's doable. So that's interesting. That's a great insight that I gained from this. That's a big area for the Colorado market. I'll talk to Eric a little bit more about that and how that is happening. But yeah, Medicare, not surprisingly, and Medicare Advantage fee for service are areas people are looking at. And we'll talk a little bit more about Medicare and Medicare Advantage in a second. So thank you for your participation. So we promised that we will talk about 2 areas in a little bit more detail, but hopefully just the right amount for you to understand what we're talking about. For me, like my experience in Medicare Advantage, I come to this from a perspective that, and is evident by the poll, that Medicare Advantage is a great opportunity for going to downside risk with a payer, and with the right payer, I should say, and we'll talk about that in a sec. When you look at the trends of Medicare beneficiaries enrolling in Medicare Advantage plans, if the current trends continue in a few years, more than half of the beneficiaries are going to be in a Medicare Advantage plan. So what does that mean for you? And why do I think Medicare Advantage is a great opportunity to focus on when you're thinking about downside risk? MA plans have a lot more flexibility than CMS, obviously. So they can really align with your geography, they can align with your system, they can align better with their capabilities in kind of choosing the right model for you to engage in a VBC setting or a agreement. And then related to that, very much so, is your ability to negotiate terms and to negotiate the terms of the VBC agreement, negotiate additional, say, removal of administrative barriers if you're going to be taking downside risk. I mean, those all come into play, and that's a great opportunity to have the right partner who's willing to do that. It makes your clinicians' life easier. It makes your patients' healthcare, journey and experience that much better when there's fewer administrative burdens and your providers have, easier time delivering the care that they want to deliver. The other more important thing, when you do have a payer in Medicare Advantage and you have a multi-year partnership, thinking out into the future, there's opportunities to influence their benefits and products designs, right? So you can co-market, you can co-brand with them, and then really have an influence on what benefits they bring to that market that really highlight your capabilities and that allow your system to generate value for those beneficiaries and for that payer and for yourself. So when you're in a downside risk agreement, you have so much more influence in a Medicare Advantage situation with the payer to create products that are more suitable for your geography and your delivery system. So that's very important. Let's go to the next slide, Jake. I'm going to just touch on this and let Jake close us out with risk adjustment. When you want to kind of assess your Medicare and Medicare Advantage strategy, and a lot of health systems are, and we're having a lot of those conversations, and I'm sure many of you are having those conversations internally. Do we stay in Medicare? Do we keep our members in Medicare? Do we move them to Medicare Advantage? How should we think about it? What are the pros and cons? So, an assessment can help you look at that, look at your results, current and past results, how those pairs are engaging you, the flexibility that they're showing, the way they're enabling your success, how they're working with you, what kind of data they're sharing with you, how quickly they're sharing the data. Those are all the kind of factors that may be specific to your geography and to your pairs and your market that you'd want to assess. And then when you come out of that exercise, this is already happening. I've seen this in many markets where health systems are already sending out RFPs to narrow down their Medicare Advantage pairs from 8 to 3. So it's a great exercise. It gives you an ability to stratify your pairs and really identify the top 2 or 3 you want to engage with, and approaching them, to go into deeper, longer term relationships with them, and really harvesting all the benefits I just talked about of a Medicare Advantage opportunity, and kind of creating a softer path to downside risk, and maybe then gaining the benefits of that, because anytime you're in a downside risk agreement, your upside potential is that much higher. So it's not a negative thing always to be at risk for certain populations. You just have to know your capabilities and deliver the value, and then harvest the benefits of that value from your pair partners. And so that's what a Medicare assessment would do for you, or a Medicare Advantage. And then Jake will close us out with kind of a little bit of detail around what a risk adjustment exercise or assessment would result in get you set up for success.
Yeah, just one more slide, Cal. I think the reason that we wanted to hit on this is because of the traction that we're seeing from health systems around risk adjustment, outpatient CDI processes, coding, and just ultimate diagnosis accuracy. So, some of the guiding principles that we look at when we're talking about risk adjustment is around optimizing the physician and the patient time at the point of care. This is an extra step for them as far as ensuring that we're capturing all of those accurate diagnoses. So making sure that we're using system, processes, people to simplify that. So that's we look at it from a pre-visit, a point of care, and from a coding perspective as well, as far as making sure that and one of the ways to optimize that physician's time is to put in the time pre-visit, having that CDI staff ahead of time really review that patient's chart for key populations. So again, first step is really understanding your contracts and where risk adjustment is going to be beneficial, and then making sure that you've got eyes on that before the clinician sees that patient, so that when they do come into the visit, it is clearly laid out for them as far as what are the opportunities, or what are the diagnoses, what are the conditions that we need to discuss at that visit. And that really is getting at the intent of CMS's program, which is ultimately we want to be addressing these conditions on a yearly basis. So there's a lot of work, there's a lot of optimization, there's a lot of opportunities for organizations in this space. And one of the things that we're seeing and organizations that we're working with are organizations that are leveraging their EHR as their technology, as far as starting with that and then augmenting as necessary. So this is risk adjustment was one of the pillars as far as value-based care, and one of the levers as far as being successful here as you continue to grow. Cal, anything to add on risk adjustment?
Yeah, I mean, just a couple of thoughts on this. How we're looking at technology and how it embeds into the process that's built around it, this is a great way to illustrate that example we talked about earlier on how we think and how we hope you think about technology and implementation of services. We are having some clients come back to us who have done risk adjustment work in their EMR a few years ago, perhaps from a technology perspective, where they activated some alerts and that the rest of the stuff wasn't really not done, the process around pre-visit and coding involvement and all that kind of stuff. So they're thinking about, they're coming back and saying, you know, I thought I had HCC implemented, I had my alerts on, but they don't know if, you know, there's too many alerts and everybody's ignoring them, or what's happening to those alerts that are popping out for providers and how annoying that may be, or maybe too fewer alerts. And you're not alerting to all the risk adjustable conditions, perhaps in a way that, you know, you could improve. So we're seeing that, and people are now coming back and thinking of this, like, what else do I need to do? Because my alerts are not working and my risk score is under 1, you know, or not going up. And I thought I implemented this. So that's, Jake, if you want to talk about that, that's a very interesting kind of development as people really dig into this.
Yeah, and I mean, some of the things that I mean, we alluded to this, but some of the gaps in those organizations are like you said, the processes, the people, the coding aspect, the full outpatient CDI, and the communication across those silos, breaking down those silos, having those shared goals from a risk adjustment standpoint. You know, organizations, this is one step into value-based care. It's kind of, you know, get your feet wet if you want to focus on one of those risks, one of those work streams. Risk adjustment is a good place to start if you've got agreements in place in the population of patients. We've also seen Medicaid risk adjustment as far as another population of area of opportunity for organizations. So yeah, and some of the tools are really around you know, having that data, having the dashboards, having that information to be able to then drive education is one of the key pieces that we've seen organizations and opportunities that they have. So yeah, be happy to talk more about this. Cal, I could talk all day.
I know.
So yeah, I think we're getting close on time here.
Yeah.
I know Anthony had one question. I was able to address it with a few responses. So, you know, Anthony, please feel free to reach out if you've got additional questions for us on the HTM or HTP program in Colorado. Cal, any final thoughts?
No, I mean, I think it's really more, I would say, a message of encouragement and really understanding that this is difficult to consider, bringing your organization together for a comprehensive look at where you are on VBC spectrum as far as readiness and how you can really align and support each other from the different business units. It's understandable, all the budgeting is done by by business units. And so sometimes with one business unit, you know, if they're not aware of what's happening in another, and we've seen this, it's hard, it has an impact on how they budget for resources, for applications, for staffing. And so, I mean, IT comes to mind a lot, but other units are the same way. So, you know, it's a big undertaking, but we feel like it's worthwhile, and folks are getting good results when they focus on certain areas, and they can achieve some great outcomes. And we have more examples of that work. And please reach out to us. And we're gonna pause and let Jessica take over and see how she wants to take us out.
Yeah, thank you, Jake and Cal, so much for being here. We really appreciate you sharing your expertise and your time with us. As you guys all saw, the contact information for Cal and Jake is included in their presentation, and that's available for download in the chat box. So if you'd like to have some of that information, please go there and grab that. I also wanted to let everyone know certificates of completion for the webinar will be available and sent out once attendance and those poll questions have been verified and confirmed, and we'll send you those NASBA certificates. A reminder, and I just want to let everyone know, we do have an upcoming event. Our Women in Leadership event is coming up on November 10th. Check that out. You can see the details of that on our website at www.hfma-co.org. And with that concludes our webinar for today. Again, big thanks to Cal and to Jake for being here. And thank you to all of the rest of you for spending your lunch hour with us. Have a great day.
Thank you. Thanks, folks.